I am Dr. Rajashree Bajaj, Deputy Director Child Health, National Health Mission, Madhya Pradesh. Facilities for treating small and sick newborn were non-existent in public health system of Madhya Pradesh. Major cities did have private hospitals which provided newborn care, but the cost was too high. The services were beyond the reach of common man because of high out-of-pocket expenditure. As a result, large number of small and sick babies died in the community. In fact, Madhya Pradesh had highest neonatal mortality rates in the country. Not only were the rates very high, but the rate remained static from year 2002 to 2006. This increased the proportion of neonatal mortality rate in infant mortality rate from 60% in 2002 to 68% in 2007. Newborn survival is directly affected by quality of intrapartum services, so state consciously invested in improving skilled birth attendance and facility-based newborn care. Progressive increase in institutional deliveries also increased the need for facility-based newborn care. In 2007, none of the districts in Madhya Pradesh had special newborn care units. In year 2013, each of its 50 districts had special newborn care units. In the short span of 6 years, neonatal mortality rate declined by 25%, and the dubious distinction of highest neonatal mortality rate is no more there. In fact, SRS 2013 has revealed that Madhya Pradesh has registered highest decline in neonatal mortality rates in the country. Challenges are huge and multifaceted. Madhya Pradesh has highest tribal population in the country. 21%, that is 1/5 of its population, is tribal. Out of 313, 89 blocks are tribal blocks. Some of these blocks are situated very far from the district headquarters and they are very hard to reach also. Some of the blocks get cut off during rainy seasons. Some villages are situated in the hilly areas and it is very difficult for a community worker to reach to these areas and provide services. Accessibility of free transport services is also an issue in these areas. Further, to have a permanent trained HR to work in these areas is another grey area. And even if we get the staff and get them trained, attrition rates are very high. So all these things contribute to the major problems or challenges in the state. Another biggest challenge is the vast geographical area of the Madhya Pradesh. Madhya Pradesh is situated in the heart of the India and is second largest state after Rajasthan. Its area is more than 3 lakh square kilometers. The state is struggling to provide equitable health services over such a large geographic area. Lack of community awareness about common diseases leads to delay in seeking health care and many lives are lost because children reach hospital very late. State adopted a multi-pronged approach for improvement. We strengthened our facility-based newborn care and linked it with communities. At delivery points, we have newborn care corners. NBSUs or newborn stabilization units are established at sub-district hospitals. Special newborn care units are established in district hospitals and medical colleges. SNCUs are state-of-art units which are being modeled by other states also. The technical know-how for establishment of these units was provided by UNICEF and Ministry of Health and Family Welfare supported us by providing the funding. We treated more than 86,000 newborns last year with an average mortality of 11%. To attract doctors, we offered higher salary packages. We also provided performance-based incentives. Teams of doctors and staff nurses from these SNCUs were sent to PGI MER Chandigarh for training, which is one of the best institutes in the country. To improve institutional deliveries, we have the concept of providing birth waiting homes. Birth waiting homes provide place for pregnant women to come before expected date of delivery and stay here where we provide them free drugs, diagnostics and diet, and when the time of delivery comes, they are provided with free transport facility to reach hospital. Similarly, we have hired boat ambulances for districts like Jhabua and Alirajpur to promote institutional deliveries. We are trying to enroll tribal girls and women in A&M courses so that after training they remain in the village and provide skilled birth attendance when needed. We are also undertaking mapping of our health facilities to improve coverage, and we are relocating them to reduce time of care. Madhya Pradesh was awarded third prize in recently concluded Shimla Summit for good and replicable practices in public health care system of India, along with Kerala and Rajasthan. We have a very robust tracking and monitoring mechanism. Newborns are tracked by facility-based data care software, which was piloted in Madhya Pradesh by UNICEF and is now adopted by Government of India for countrywide use. Automatic SMS alerts are generated through this software at the time of discharge, and the alerts are sent to community workers as well as parents of the newborn. Scheduled facility follow-ups are there at 7 days of life, 1 month, 3 months, 6 months and 1 year of age. SNCU software tells us that even after successful discharge, 3% of babies die in the community, and 80% of these deaths happen within first month of discharge and at home. Therefore, it is all the more important to track these babies, and they are called for checkup at health facility on day 7 and 1 month of life. This ensures proper growth and development because these tiny and fragile babies are likely to develop suboptimal growth, visual and auditory deficits, and developmental delays. States of Maharashtra, Haryana, and Assam had visited the state for training in newborn care database software. States like Andhra Pradesh and Bihar had come for exposure visits to Madhya Pradesh. We also had a delegation from Afghanistan for learning about our newborn tracking mechanism in communities. Similarly, we had a team from government officials of Sri Lanka to experience the maternal and neonatal interventions in the state. Other states are replicating our model of SNCUs and the software. Our policy of providing high package of salaries and performance-based incentive is also being followed by other states. Other states in India are replicating our model of SNCU and software. Our policy of providing high salary package to SNCU doctors and performance-based incentive is also being followed. Our database software has more than 2.5 lakh entries, and this is the largest database available globally. The data is used by district people, state officials, academia and researchers alike. Cause of death analysis revealed that highest number of deaths are occurring because of respiratory distress syndrome. State undertook a study wherein antenatal corticosteroid was used for pregnant mothers who were going in for preterm labor. Results of the study were accepted by Government of India, and now the guidelines have been issued for other states to follow. Our policy is to maintain and improve the quality of care being provided through these units. After achieving numbers, the focus is on providing quality care to SNCU graduates. As we discussed, these babies are likely to have various deficits, delays and disorders. We are planning to link our follow-up OPDs with district early intervention centers of Rashtriya Bal Swasthya कार्यक्रम. Early intervention centers would be identifying the defects, diseases and deficiencies in these newborns, and they will be corrected soon.